My name is Fawzia Salahuddin, and I am board certified in internal emergency medicine and now finishing off sleep medicine. And I'm very privileged to be here. Thanks to APPNA MERIT, I've been watching quite a few of your videos, very intense but to the point. So I love it. I hope to keep it that way. I'm also elected president for North Carolina chapter and happy to be here. With this, we're going to try to be focused, and today's talk is on the guidelines from American Academy of Sleep Medicine, especially in light of COVID-19. So there's a lot to say about sleep medicine, the PAP therapy and insomnia, but we're going to focus towards sleep medicine towards COVID-19. Let's see. What we're going to cover today, our objectives will be guidelines for safe practices for sleep medicine, according to American Academy of Sleep Medicine, and FDA and the government authorities guidelines. Non-invasive positive pressure ventilation, its usage both for our patients at home, which are our current patients who are severe enough to use it, as well as the use of non-invasive positive pressure ventilation for hospital patients, but not critically ill. Then we'll touch briefly on Medicare guidelines, waivers for telehealth delivery, use of non-invasive positive pressure ventilation, and managing them outside the ICU, especially when you want to spare the ventilators for the critically ill patients, and different strategies that we see slightly more than baseline for insomnia, its prevalence, and their legitimate worries for patients due to COVID-19. These are some of the Medicare waivers that are helping us. Being in the university setting, we cannot stop seeing patients, but there's, I would say, probably 60-40 ratio of patients that we see, emergent patients that we see still, and most of them have transitioned into telemedicine. And for the first time ever, because it's the first time ever, we as in United States, and I'm sure in Pakistan, same things are happening, that telemedicine has evolving field for first time ever. And these are just some of the guidelines that we can use. And I'm going to give these slides to APPNA MERIT so you guys can get into the details. I don't want to read too much into it. And these are CMS guidelines. It's very hard to change CMS. So this is pretty strong stuff. Specifically, we're going to focus on COVID-19. So they have, CMS has finalized that we really had to run through hoops to get our patients PAP therapy. They were required to undergo titration studies, and as you know, titration is kind of banned now here anywhere because of aerosolized mode of transmission. You do not want to bring your patients into your lab, let alone in the hospital. We have very limited negative pressure rooms, and we were never prepared for this. So none of the labs that I know of have negative for titration. So we're doing titrations are impaired because of these laxities of guidelines prescribing PAP therapy to our patients, so depending on their diagnostic. So you do need a diagnostic or home sleep studies, and we'll get into it, that how we are managing that right now. These are just some of the data that came out on American Academy of Sleep Medicine website. Is as of April 17. Look at the number of patients we've started seeing as telemedicine patients and the primary care. So 35% of urgent cases are being seen, and definitely follow up. And when I say telehealth, it's either through the computer or web-based, or most patients have their smartphones and they can download these applications and use them as a way of communication. This limits their ER visit, of course, and limit the transmission and exposure of the patients, because remember, when they come to sleep medicine world, they already have a lot of things going on. And every disaster brings an opportunity. So these are some of the websites and some of the places where people can apply for grants. I know we have for different things, and they are approving these grants to along the lines of COVID-19 coronavirus to help patients and for us to manage them. Because as we've been, as you guys all of us know that the treatment is prevention. These are some of loans and grants waivers and some related guidance, and that you guys will have it available. Some of the deadlines are coming up, so please avail them if you're in that group of people who like to apply for grants. With this, I'm going to start up my, a week ago, we got this consult, well, a few days ago, but the patient has been here for a week in the hospital. So JD is a 68-year-old with history of prostate cancer, comorbid obesity with BMI of 42, diabetes mellitus, tobacco use, possible COPD. There is no PFTs on chart from our hospital. On oxygen, 4 to 5 liters. This has been in the last few years. I would say 4 years, because he was initially started on 2 liters and then went up to 5 liters at present on ambulation and at rest, and as well as at night. He had been, so a little bit background on JD, he has PAP therapy, Cpap. So there are various types of PAP therapy. Cpap is one of the simplest modality. And so patient is on that, and he now got oxygen. These machines probably last good 5, 6, 7, 8 years. So it's kind of old machine. According to his wife, they did not have oxygen port to have oxygen bleed into his PAP therapy. So he was not using it. Now you can see the picture. He's morbidly obese with multiple comorbidities. He's supposedly stopped smoking, and he was in his kitchen cooking. He spilled things and had a small burn, superficial stage 1 burn when I saw him around his face. So lips and stuff were not burned. And so ambulance was called because he's so big, his wife couldn't pick him up. So she called 911 and brought the patient to us. When the patient came, he was almost obtunded, requiring 8 to 10 liters of oxygen from the ICU. He did not get intubated. All the labs were ordered, including COVID-19 coronavirus testing. And his BNP was 943. He did get his pulse ox to 95, 96% on 100% oxygen. His chest x-ray showed some pulmonary infiltrate, but he's been in the hospital 2 months ago. I compared both the x-rays, they were the same. He had some little bit right-sided pleural effusion, 1+ pitting edema on the lower extremities, could have been just chronic venous changes or right-sided failure changes. And his blood pressure is hovering around 110 to 70s. So his ABGs, I thought I had 2 ABGs, yeah. Baseline ABG 7.26, PCO2 of 96, PO2 of 83, and oxygen saturation 96% on 100% oxygen. So he had PaO2 or FiO2 was around 160s, 170s, but COVID came back negative. He was admitted to the hospital, to ICU because of high oxygen. So we have we've kind of evolved. We never had that kind of ICU. So one is now all COVID patient ICU, and the other one is non-COVID patient ICU. We are still wearing masks and stuff. So this patient required more than 24 hours of bipap therapy with filters, we'll talk about it, and non-rebreather mask with a leak valve. So this is now that we've never thought we could use bipap in this kind of setting because, you know, with all of these non-invasive positive pressure ventilation, there is a high risk of aerosolization. So now we're trying to get him off that much oxygen. He's COVID negative, treating as community-acquired pneumonia and trying to diurese him also at the same time. He gets echocardiogram, transthoracic echo with normal ejection fraction. He's still like 6 liters of oxygen, trying to this date, the patient is getting into to get into the step-down unit. His repeat gases, after we've done like a couple of days of BiPAP, now he's only on nighttime BiPAP, which he should be at home, but he doesn't have the machine. And now his gases are 7.43. The acid-base balance is normalized, PO2 of 68 and PCO2 of 70. And this is on 6 liters of oxygen, 95% saturation. He was a little oriented ×3 when I saw him. And we'll come back to more of that. I cannot see questions, guys. So if there's any questions and you have any questions on this, you can, I'm gonna let the moderators do it because I can't see anything else here if there were any questions. And we'll come to this case. This gives me an opportunity to explain the high demand, and we know we're kind of third, fourth in the row, United States and Pakistan also, that now we are seeing what other places like Italy has seen already, is the shortage of ventilators. So we have a couple of websites where those of us who are doing sleep medicine now can see that PAP therapy requires a lot of dedication and persistent in using. And so a lot of the patients, once they've done their landmark of 3 months, if their machine is there, they don't really use it as much. They do require a lot of motivation from family members, from primary cares, and some of them are always, there's good percentage that uses 100% because they know they feel better. So there's a shortage and call for the and PAP therapy if the patients or their family members or their grandpa are not using it. So they're looking for donations because they're using those machines baseline and transferring using different methods to minimize aerosolization. And I've actually talked to people who are using it in the private sector here. Right now we have enough, so we're using the ventilators, but the BiPAP for non-COVID patients we're using if they needed to. And then there are ways that people have taken grants, and I think that's a very great opportunity also to use these machines, minimize aerosolization, and use them for 2 categories of patients, either patients who are COVID negative, and like my patient, we use BiPAP, or number 2, for those patients when we are weaning them. And as those of us who've done ICU or do ICU, we know that you just can't turn the switch off. You can't have a patient on ventilator one day and then next day take them off. You do require weaning. So these methods can be used in weaning, so that ventilator can be used for a sicker patient in the ICU. This method, actually, I'm looking into this also. It's a great opportunity, actually. Before the disaster hits, we still have not reached the peak in the United States. And the experts would correct me if I'm wrong. So we will need this. 2 universities I know are looking into this, and this is the end of combination of engineers and intensivists and ER docs, pulmonologists. So here we see, I'm not sure if you can see my arrow. This is an example of a PAP machine. You know, they're kind of, they can be this small, you know. I don't have a sample of it here. So they are kind of a small machines. And this is a hook. It's a tubing, but it's not that small. And for PAP, it has to be pretty big for from patient's bed to that side of the bed. So there is kind of bigger than this tubing. And then we have an oxygen port. You know, for some patients, we need a port. They need to wear oxygen in addition to using PAP therapy. And here are the filters, and I'll talk more about these. So here are the filters, and they're claiming that is 99% virus can be filtered here. And then here also we can use a leak valve, and here is the the ET tube, right? So that's for the patient. And if you're using BiPAP for non-ventilated patients, or CPAP, I would say BiPAP more because, you know, once the patients are that sick, they need help in ventilation, and BiPAP modality, depending on their pressure support, we can ventilate the patient. And actually, this is BiPAP and CPAP, but as sleep doctors, we do give patients VAPs and VAPs and IVAPs also. So they can be used as a temporary measures, as a transition measure for ventilation of these patients. So these are some of the examples. I don't want to just read off of the slide, but you can see it. Now, this is a little busy slide. I'll give you the gist of it. These are US FDA guidelines for non-ICU patients. For continuous CPAP is continuous positive airway pressures. Auto CPAP, which is another cool way of self-titrating patients. As you know, when we all sleep, we have different stages, and we'll come to it, of sleep. And in REM, when we see most of the obstructive events, this auto CPAP really helps instead of just fixed pressure. It's a very good sensing device which uses oscillation method and gives the amount of pressure depending on the airway resistance. And BiPAP therapy, and mostly that's what we're using actually, is BiPAP. We want to give what we want to give so we can have a fixed pressure support to ventilate these patients. So BiPAP machines are really called for. And these are the typical methods we treat patients for sleep apnea, overcoming the obstructions. And in COVID-19, what we're seeing is the patient's lungs gets affected. But mind you, now this is no way replacing ventilatory supports or ventilators because we cannot, as you know, and the intensivist in this talk will also verify this, that patients COVID, unfortunately, with the RDS require really high pressure and high oxygen. We cannot give through these machines, but we can help some. So we got to be really careful. So we have oxygenation port, right? I showed you in the earlier picture. So the oxygen enters, and then the oxygenated air is filtered, okay? So any entrance, exit from the lung or giving in and coming out, we want to make sure PAP therapy is, we're limiting our purifying air. Like right now in the hospital, our patient, we have a filter so we don't infect our machine. We do this all the time. Even before COVID-19, we had filters. We don't want to infect our machines. So we should have this filter here, right? And then it's delivered through an FDA-approved endotracheal tube. And then you're going to have the loop, right? You're going to, patient, and I'll have more pictures, you're going to have an entrance, and then the exit limb, how you're going to breathe out. So you want to make sure, that's very technical. And then before it comes in the environment, you want to make sure that that's also filtered. And for COVID-19, so the other thing is simply, American Academy of Sleep Medicine is advising, if you had very mild sleep apnea, mild is considered 5 to 10, apnea AHI index of less than 15 is mild. and more than 15 is severe enough. And actually in the VA population, we don't even treat less than 15 unless it's really symptomatic or comorbid conditions, and patient wants to use it. So for those mild cases, the American Academy of Sleep Medicine guidelines for COVID-19 is you do not need to wear PAP therapy. And if you have oral appliance, you can wear that. You can sleep on the side. So minimize, because as you know, if you have secretions or you have, God forbid, you have COVID, earlier infection is in the mouth, in the upper airway, nasopharyngeal areas, and you may recover from it. Not everybody is getting infection into the lungs. So you don't want to push with PAP therapy down there. So you're avoiding it. That's the thing. And you don't want to really even see very sick patients, mild patients. You want to see the sick ones anyway. They are also advised to, if your patient is using baseline PAP therapy for the COVID-19 era, they need to be by themselves, because we're not changing these machines for 8 million machines out there in the United States. We can't even make that much filters. It's no use for it. There's no requirement for it. But we can advise they can sleep in the guest room, or they can sleep alone close to the window, or if they are stuck with it, then with their spouse to sleep in the same room, then those ones you want to think about that. Just risk stratify each single patient. So this goes into the environment. So you want the filtered air to go into the environment, and so you limit the virus spread. This also is a similar, so how did these two universities doing it? They actually are making their 3D printers of the ventilator, how they're gonna make the machine, their PAP therapy into the ventilator. And this is the website, the ventilator SOS. There's a form. I actually went to the website last night and looked at it. What it entails is there's a form, and they'll ask you what type of machine it is, what is the SN number, because that's your identification. It's individual actually. For every patient, there's an SN number provided to them. So we can register them here. So down the road, let's say all this is over, hopefully, we can give these patients back, not their machines, but we can give them the latest machines down the road. And in this way, they can tell, because all of these machines, well, I shouldn't say all, most of the machines, at least in the United States, our PAP therapy machines given to the patients have a SN number, and we can locate where these patients are. So we can, they can fill out the form and register and taking donations here. We're gonna move on. So how do we know? This is through the different places where we have seen already went through disaster, how the ventilators were needed, especially in Italy, how it was horrible to see it, that how they had to risk stratify that only if they were old or they had comorbid conditions, the doctors had to make the decisions. And I, as a physician, I would have a very hard time doing it, to give the ventilators those who could survive. So here we have this opportunity. Now, this is what we're using, right, in the hospital. As you can see, it's quite pricey, and the efficacy they're claiming is more than 99%. Like I said, I didn't talk to these people or talk to ResMed representative, but because I prescribe more of that, but I have no disclaimer I'm not working for any company. So you can see down here, their summary of the viral filtration efficacy and their related products. And that's where we are interested, right at the bottom. You guys see that? And you want a single flow, so, and actually here they're saying low resistant bidirectional flow, so that the virus and the bacteria are filtered. Mostly we're interested in the virus for right now. Here, this is again the same way. Now this, you can see this more better. I think that's why I put it there, background of orange. And they're disposable. Okay, so in this slide, you can see after you've minimized the transmission, and CDC is recommending that patients and this is all, they're significant, they're big white papers. Actually, I read 2 of them. It's very strict guidelines. You can't just go off and do this. So the CDC has its guidelines also, that patients who have low oxygen saturation, who can do this, very high oxygen requiring, we can do this as a transition from the ICU to the non-ICU step down, where we're trying to help these patients extubate. And those who can't in the earlier phase, if we've caught them and they're not feeding, we can't oxygenate them. Basically, it's oxygenation and ventilation. And if they come to that point, they're developing stiff lung, they're going to their ICU. Okay, so we've talked about this. There's also a great way of shorten hospitalization. If you help these patients early enough, yes, you can. And actually, I was reading something yesterday also, is most of it was with you guys. I was on the panelist yesterday, that these patients, they never make it out to the hospital. Unfortunately, they die at home. So, or they come so late that we just can't help them. So again here, so this is a very important slide. What do we need to transition to use these PAP therapy machines when we modify them to help bridge, is the word, bridge the ventilator shortage that we are seeing and also foreseeing. So we can save the ventilators to the very sick ones. So there are VAPs, which is ventilation assisted PAP therapy. Then in PAP therapy, the other thing is VAPs is we use it. Sleep doctors prescribe VAPs. I have a few patients with neuromuscular disease like ALS or obesity hyperventilation syndrome with chronic hypoxemic respiratory failure and hypercapnic respiratory failure patients. We do use VAPs. The advantage of VAPs is you have alarms in there, because these patients are neuromuscular diseases, or they're never going to tell us anything, or the oxygen is low, they can't say. So that's another thing that's lacking in Cpap and bipap devices, which is more abundance of right now, that we're going to get donors. So we have to put alarms there, and then make sure we have a leak valves and filters. So these things have to be mandatory there before we can use them. Although in ICU, as you know, we are running short on nurses and staff also, the ratio between patients. And one of the ways in ICU, we put the patient, we can't really see that what is the pressure, what's the plateau pressure. We have to go in and check, right, unless the machine is making alarms. So in these CPAP and BiPAP, we don't have alarms. We have to put alarms in there, and the leak valves. Then again, you have to worry about your workers, make sure, especially when we are using, there's nothing 100%, right? Closed unit is for the ventilated patients. Even on those, there's risk for aerosolization and risk for we should all be wearing the N95, at least N95 gloves and the shield if we can. It's very good to have the proper gear if possible, but reality is that we should have all of these things. Make sure that when we are about to intubate them, they're in the negative pressure room, use glidoscope versus the regular intubation, proper mask, fitted mask, and interface and filters. So this is what I wanted to actually show you guys. And I don't know if we have any intensivist in the audience. So regular PAP therapy, we have, when we are giving these PAP therapy to my patients, the mask is very different. Actually, I had earlier a picture of it. The mask is different, and it has holes in it. So because we were never thinking of all this, right? So now we have to have the mask which should not have the holes, so that aerosol. So there were 2-3 places where there's going to be aerosolized, and how am I doing with time? So aerosolized, where the possibility of infection. Here I wanted to show you. So you don't want to have this. So you guys are all going to get these slides, right? There's one slide which has some spelling errors, and I'm going to correct. But here you can see this is you don't want to use. And why? As you can see, do you see my arrow? See there, here's the air will come out into the into the room. So we don't want that. So any potential places where they're going to be air can leak out, you want to make sure there's a filter. So here's you're going to get a proper mask. You're going to get a filter here. You're going to get wherever there's possibility of exiting, you're going to have a filter. But this is, you're not going to give it to all of your patients. And as I already talked about, what you're going to tell your patients. So with this is one of the white papers that I read on ResMed. And like I said, I don't have any attachment to ResMed, but I use that more because I can see it online. I can see my patient, what my patients are doing on this more easily. I do use the other one in United States. We use Pikel is there, and Respironic is there also, actually. We use AVAPs for Respironic. So these are just different companies, and that's their thing is that Stellar, all of these companies are also making modification and making their machines, like bipap ST means they're the backup rate. You can put a backup rate and can be used when patient doesn't breathe. You can force breathe, set a rate and then you can let them breathe. So this is another good slide. These are the websites links that I've put up there. Very good ones. This comes to our new era. How am I doing with time, Dr. Shahid and Dr. Iqbal?
You have about 5 minutes left.
5 minutes, okay. This is the key slide, okay. So this is very common. Actually, we started when like end of January, February. We started this last month, like March, April. April was like insomnia. Like, hey, this is legitimate, people get worried. There are times when I'm on CNN looking at the news, I can't sleep. So let alone patients who already had insomnia to begin with. And what is insomnia? Technically, it's a persistent difficulty in initiating sleep, worries, mostly it's worries. Sometimes it's medications, the time of the day, day you take medication, that keeps you stimulated, or caffeine intake. So it's basically defined as persistent, frequent difficulty initiating sleep and then maintaining sleep once they go to sleep early, but then when they wake up, they're just worried, so they just can't go back to sleep. And then it requires a very thorough history, actually. Patients, when they come to the sleep doctor, they talk, I can't sleep. And what that does, it affects the workforce, especially, or anyone, actually. If they don't sleep, of course, they cannot function next day. A lot of our insomniac patients, and now what we're doing to these patients who are already having problem in sleeping, we're isolated, right? We're quarantining them. So these patients are quarantined, they have comorbid conditions. Their family members are worried if they're lucky, they're not alone. And in Pakistan, it's different, right? We're not going to be, it's better in Pakistan socially, but this is physical distances is required. So these patients feel very lonely, isolated, and more worried. And this is legitimate, actually. It's not pathological, but they already had an issue and it's just getting worse. So how do we define insomnia? It has to be more than 3 months to call it chronic, and I think we're going to see more of it. And they're having hard time sleeping more than 3 times per week, at least 3 months, to meet the criteria for chronic insomnia. And actually, it's a huge lecture for itself. So I'm just going to, let's for COVID-19. This is just, these numbers are worse right now. So these are United States numbers. 33% of the adults suffer insomnia intermittently. That's like 1/3 of us. 20 to 40% of children and teenagers, and we're going to see this problem. We all have kids. Well, in general, it's very hard to now take electronics from them. There's nothing to do. Schools are closed with this era. So the limit settings become very important. And then it's a very high price. And like I said, this is not the COVID numbers. COVID numbers will be increased. And what they're saying in the United States, annually, there's a direct cost of insomnia to US economy, and it exceed $90 billion. Insomnia can reduce life expectancy, increase cardiovascular events, and actually right now is compromise immunity. If you don't sleep, one of the things that happens in sleep is you build better immunity. People who are insomniac or don't sleep can gain weight, diabetes, seizures threshold reduces, asthma. And it actually affects everything in life. If patients don't sleep, their judgment is very poor and performance is poor, and there's multiple data in sports. They don't do good sports if they don't sleep. A lot of the time we see other comorbid conditions with it, mental health, substance abuse. And this, I just wanted to give you a brief touch of insomnia, is how sleep affects us. What do we do in sleep? So as you can see, sleep efficiency means the amount of time you spend in bed and how much time you're actually sleeping. And this, the next one here is the sleep duration, how much you're sleeping. So you can see the difference that your executive functions are actually affected, let alone the amount you sleep, the cognitive flexibility here we're saying in all these, everything comes at a cost, right? In America, in industrialized places, everything comes at the cost of sleep. So we've got to be really careful with this. And can't resist telling you guys some of this, the different waves we see in patients. These are the first two are more awake, alertness waves. That's how we know we're sleeping in the lab or not, different stages of sleep, and then the REM sleep. And this is what we see in patients with insomnia. So here, the top lines are the stages of sleep, the brain waves that I showed you earlier. So all this gray is awake. Then the N1 is colored here as yellow, so which is kind of a transition zone. The more you see this wake in N1, see it's followed by N1. This is the first stage of sleep, is where we have the worsening of the cardiovascular effects. As you can see, this is the heart rate line. At night, anything more than 90 while you sleep is tachycardia at night. And the more you have that, there's more chances of having any cardiovascular event. So as you can see, then this is blue, then the turquoise is N3 sleeps, that's slow wave sleep that reduces as we age. It comes back with sleep deprivation. And then green is N2, that's good, memory building, processing things happen in all this happening here in green. And then, and you see less of this in patients with dementia, actually. So the processing, the spindles that are made in thalamus, they are going to the cortex. It's less, as you see less of this, you get more dementia. And then finally, this pink one with the black is REM sleep. That's the sleep when you're dreaming sleep, and where all the muscles are paralyzed and except eyes and the diaphragm, and you process things. So here we see, some sleep apnea, but we can move on. How do we manage? How are we going to manage? The primary cares are seeing the insomnia, or your patients are coming to you, doc, I can't sleep. We see them when they've exhausted their resources with primary care. So we take a good hour history in this. When the patient come in for insomnia, you have to walk them through what's their daily routine, things that you can change, simple things, telling patients you want to do this, take this pamphlet, it's not going to work. So you kind of have to figure it out how you can help the patient. Even if it's an hour more, I usually tell the patients, even if they sleep just an hour more, that will really help them. They can't let them function a little bit better, right? A person is, for example, coming with their teenager, not able to sleep. I usually ask what time the whole family is sleeping. You can't not expect a teenager to go and sleep if the rest of the family is awake. So it's just kind of complex, but it works. When things we've tried, we also work in conjunction with our mental health folks with CBTI. So there are a couple of agents that are used for insomnia, right? I never give out the first time come around. No, they're not getting medications. We got to kind of change their behavior. There are different sessions of cognitive behavior therapy. We kind of help them, keep them sleep diary, a log of what they're doing. And then if we have to use, there are a few FDA approved medications, because you see, you don't want to have them hooked up to the medications, because then it's very hard for them to sleep without it. Although, it's an industry, we have medications that we can use for chronic insomnia once their underlying issues are resolved, and that their insomnia is affecting their day-to-day life. So these are some of the medication, and this is a very good way to remember. For the primary care setting, the one that I would advise to give is melatonin, and you have to make sure that the melatonin just not on the internet or regular pharmacies, the compound pharmacies who just have because melatonin has a lot of impurities in it, so you want to make sure you have the quantity. Don't get the chewable ones, because you can just get a lot of it, so you don't want to get too much melatonin. Rimelton is a long-acting one, and non-benzodiazepine Zalplon is less than an hour. So if patients come in, they have a very hard time starting sleep, but then they can, once they fall asleep, they can sleep really well. The other thing I do is if they have a hard time sleeping at night, don't let them take naps. Avoid any caffeine after lunchtime. So those are things, some patients are very sensitive to it if they sleep. And as you know, coffee is an antidote of adenosine. Adenosine builds up. That's how we sleep at night. And then washes off. But if the patient naps or take coffee, and that's an antagonist for sleep. So, and these are the long-acting ones we never use, but the short-acting ones, these two, less than 1 hour, or this is for maintenance. And usually we don't want to give them to get used to it every day.
Dr. Fawzia, this is Iqbal. We have only 10 minutes left for questions, so will it be possible to summarize?
Yeah, so this is just my second last slide. I think that's the last slide. Second last slide is what happens when you don't have sleep restrictions. As you can see, this is in teenagers. Sleep restriction can cause prefrontal cortex and parietal lobe loss. With this, I'm going to end. This was my last slide, and take questions. All right.
Thank you very much, Dr. Fawzia, for this brilliant lecture. I would like to open the question and answer session. I will forego the introduction of the panelists today because of our limited time. I thank everybody who has been able to attend, from the attendees and especially our panelists. So let me ask you, the first question is from Dr. Mariam Motin, who's one of our panelists. She's a non-invasive cardiologist from California and a professor at the university, Loma Linda University. Okay. So the question is, can you please comment on pulse ox monitoring of COVID suspect persons at home? That's part one of the question. The second part is, and this is probably more applicable to panelists from Pakistan, is I understand that the availability of pulse oximeters is getting limited in Pakistan. So would you please comment on domiciliary pulse oximetry?
Sure, absolutely. Excellent question. And We do use pulse oximetry. We see all patients, all sorts of patients. Being in the university setting, we see patients with multiple comorbidities, and some of the kids, kids with Down syndrome, kids with knee impacts, with
what about COVID-19 suspect patients at home?
So we
monitoring?
pulse ox works, and you can check if there's a way, instead of freaking the patients out, we can document that it goes that low. The only problem is that if there's no nail polish, they make sure all the things that we do regularly for patients, for regular patients, you don't want a way to come off. You can put tape around it just to get the monitor of it. It's good to see that night to night variability, whether it actually is there or not. The person has to read. So what we make sure is that pulse ox is correlating with the pulse rate of the patient. So you don't want to, it's off off the bed, and you're reading that. And if there's no pulse with it, then you just can't see it.
Thank you. So there's a question. The second part of the question is, I will direct it to Dr. Nighat Ahmed, Dr. Bushra Jamil, and other panelists from Pakistan, Dr. Shamsa Humayun. Is there a difference in the COVID positive cases in Pakistan and Afghanistan? That's one question. Second part is there a limited availability of pulse oximeters? That's what you've heard. Is that true of hospitals in Pakistan? So,
Assalamu alaikum to everyone. Fawzia, that was an excellent presentation, and thank you, Merit APPNA, for this opportunity. As we all say that ये वाली जो चीज़ हुई है, इसके अंदर से बहुत अच्छी चीज़ें भी निकलेंगी, and one of them is telemedicine, which we are doing, and I find pulse oximetry very helpful because I read that information that home isolation and home quarantine has been allowed by Punjab government also. So, but most of our patients are very reluctant to get tested, and they were, we had instructed them to have pulse oximeter at home, and they were reporting their their saturations. I'm not aware of any deficiency of pulse oximeters. I know you can find them even at pharmacies. So I'm not aware that there's an extreme shortage. Sometimes you have to look for them, but they are there and very helpful for us, at least here.
So, Dr. Nighat, can you elaborate on what are your criteria if you are doing monitoring remotely pulse oximetry at home? When do you bring the patients in? What saturation level, or what are the criteria?
Basically, the criteria is that if they're below 96%, we tell them to, just immediately, call the ambulance or, get shifted to the hospital. And you won't believe it that most of the time, even in that stage, they really don't want to go to the hospital, and they say, we'll try, we'll get better. So that's why, earlier somebody was mentioning that patients are not coming to the hospitals because of the issues with, the police taking away and all that. But now, since home quarantine has been, approved, so most of the patients prefer to stay at home, even when we tell them that we suspect that you have it and please get yourself tested. Especially our patients are immunocompromised. All of them are on some kind of disease modifying agent. They have received biologics, and when they complain of fever and they have cough, and we tell them to test yourself, and they don't. And surprisingly, we see very few COVID-19 in our population. We're gathering our data and quite surprised by that. So our patients who are on DMRs have biologics. Are they different from others? But as I said, we have been successful in keeping patients at home, but we don't know whether they have COVID. We suspect that they have it because they never get tested. But if when you look at the patients on tele and the patient is, just by looking at the patient, sometimes what we say is eyeballing them, that they don't appear to be, in any kind of distress, and the sets are okay. They are staying home and doing well. And that's
Yes,
what it is.
that's excellent. That's what we do is, we saw one of my professors, colleagues had, we get outside referrals, and we quickly saw the patient from their home on tele, and that's how we could triage the patient, whether they can go to the ER. But the thing is that we've got to use telemedicine to screen very quick. Patients have mobile state-of-art phones, actually. And they have iPhones, they have different types of phone. They can download different applications and then see you.
They're doing very well with that. Even patients from like Okara and, far-flung areas,
Yes.
Everybody has smartphones, and
Yes,
they do
smartphones are
very well
there.
about that. And once you look at the patient, you're talking to the patient and try to, I think that gives you some satisfaction. That doesn't look that sick. I know the patient suddenly crash also. Can I have one question from you? Because lately, all this that is histopathology reports of the patients in New York and everything, that all this is microthrombosis, and what we are seeing is in the lungs also is just thrombosis everywhere, microvascular. So what is your take on it? So we were like, not thinking about this.
Yeah,
When we started with COVID.
that's true. So as you know, in the COVID patients, they decline pretty fast also. Main issue is oxygenation. So when they're short of breath, even talking to you, let's say you are triaging patients, and they're short of breath and they look sick, that's going to be the first thing. So the other things are kind of going to be thrombosis. I saw some vasculitis on different forums are there, but and that's very rare to see those vasculitis things, COVID related, come first, and lungs doesn't get affected. So you're going to see them not able to breathe. That's where it's attacking, right? So you're going to see that first, then just the vasculitis. Yes, I've seen some of the vasculitis, but I would think, I don't know what the others think, my intensivist, if they see thrombosis first, it does come. I mean, it's causing the whole cascade of chemical transmitters. Inflammation is caused, so it's like it's like a very septic patient that we see. Everything is going to go down. So those patients are very sick. Those that we have in our ICU, COVID ICU, they are very sick. So you'll see that. But just to have vasculitis and thrombosis isolated, not sure. Then I would just treat it symptomatically. I would call them very lucky that they don't have lung involvement.
I'm sorry. I thought I think I couldn't explain it because the study which came out of like 70 autopsies which were done on the lungs, and they just showed microthrombosis in the vasculature, and everybody's thinking that the ARDS and the lung changes which we are thinking is viral infection or whatever it is just thrombosis. My question to all the panelists and to everyone, are we going to rethink our strategy with patients who come in with shortness of breath?
So this is Iqbal Ahmed, and all the intensivists can jump in at this, but from this has been an evolving understanding of the disease as recently or certainly as recently as March. This was being observed, and it has been reported in China as well, that up to 30% of patients who are admitted to intensive care units, even before they have evidence of pulmonary embolism, they have deep vein thrombosis. So this was done confirmed in a Dutch study. Then there's a study at Brigham and Women's in Boston, where about 30 to 35% patients already have ongoing thrombosis. So the protocols are changing to recommendations that all hospitalized patients should get some form of screening for DVTs and other thrombotic events, and should be placed on prophylactic anticoagulation. And certainly the ICU is facing a lot of challenge in maintaining therapeutic anticoagulation with thromboembolic events. So there seems to be almost a DIC picture, which is very resistant to anticoagulation with traditional agents. There is an escalating dose of low molecular weight heparin and other heparin alternatives given based on the D-dimer levels. So, I'm happy to share that with you offline of various protocols. So definitely this is on the radar of intensivists, and this is not a typical ARDS sort of picture that is typically seen in other forms of viral infection and pneumonitis. I hope that answers some of the questions. Dr. Bushra?
Assalamu alaikum. Thank you for an excellent presentation.
Thank you.
Regarding the, regarding the situation in Pakistan, I think people are realizing that anticoagulation should be initiated whenever patients are not responding to the regular measures, and it is becoming pretty much a routine, especially for sicker patients and those who are on ventilators and are difficult to actually manage. The other thing about somebody in the chat asked about availability of respiratory therapists in Pakistan. So there are universities which are actually running courses for diploma courses for training of respiratory therapists. And at our hospital, which is FAAN University Hospital, we have 2 respiratory therapists, but there is an issue with the training. So once you recruit them, you have to just bring their practices up to a certain standard before you allow them to operate on patients. So I think respiratory therapists should be supported and should be available to all hospitals which admit patients with any kind of respiratory issues which require non-invasive and invasive ventilation.
That's excellent.
I just have a question to Dr. Bushra. Again, there was another question about differences in patients between Pakistan and Afghanistan related to COVID-19 presentation.
I have not seen any Afghani patients, but you see there are genetic differences. For instance, if you take the example of TB, which is my area of interest, people behave differently when they are infected with mycobacterium. So the KPK population rapidly, and Afghanis develop rampant lung pathology once they are infected with mycobacterium. And when you compare them with other populations, they have more severe course of infection. So I don't think it would be unexpected to see differences in disease pathogenesis in people belonging to different ethnicities.
Is there any data on that being collected going forwards?
I am not aware of that, because we are currently looking at our indigenous population. We do get a lot of Afghani patients here, but at the moment there is no international travel. So we are looking at our own indigenous population, but we can compare databases once there is ample data available from Afghanistan.
So thank you very much for that comment. It's also sort of reinforces my own experience when I was working in Pakistan in the chest ward in Mayo Hospital. And then I worked in the Afghan refugee camps during the Soviet invasion. And the rate of miliary tuberculosis in the Afghan population was very impressive, with late presentations, very young people getting miliary tuberculosis. So it may be interesting to look at this data going forwards. There may be 2 different disease presentations based on the genetic makeup.
So, Dr. Iqbal, there's the two questions. I was just skimming through it. In the questions and session is to how to clean. I actually advise these tubings and PAP therapy and stuff. Now with the COVID, you want to make sure when they're in the hospital, you're going to clean these tubing the same way. And actually the tubings that goes to the patient up until the end, that should not be used on another patient, right? So that's number one, right? And then for the same patient, you want to clean it the way you usually clean daily with your standard that you clean with. Most of our cleaning things, there's nothing new. We were cleaning them the way we used to. So same way, don't buy things over the internet. Then this is for home now. We never tell patients to buy. There's industry out there to cleaning solutions. And sometimes when you use too much of these cleaning solutions, especially the mask, the seal, and the other thing is the interface. The interface is simple, a cloth that goes on between the skin and the plastic that goes around it. That avoids any skin breakdown on these patients. And they are nothing. वो बनियान का कपड़ा नहीं होता, उसको वो लोग काट के बनाते हैं, and that's called interface. And that's very absorbent for any secretions that we get on patients between the mask and the skin. So it kind of is a barrier for that. And actually, I'm going to put those pictures in before I send you guys. So that will be really helpful, cleaning things. And then I saw that how much it will be costing. So, so some of our patients, even in the United States, they have no insurance, right? So we usually do home sleep testing on those patients regularly without COVID era, especially now we have cleaning ways to clean them, disinfect them, and they bring the home sleep test back to us, and then they buy their own machines. So the machines on mycpap.com is like $250, and it can range from a few $100s to $5,000 to $7,000, right? Like ASV machine, which is more for central sleep apnea, that's like $7,000 machine. So these machines are costly, but Cpap and bipap and autopap are not, and they are kind of less than $2,000 machines. So that was one of the questions on the chat session. And I'm sorry, I think I was not putting the headphone on. So were you guys able to hear? Some people were saying, look, speak into the mic. Hopefully you, and I'm looking at it. If there, Dr. Iqbal, do you see any other questions that we see in here?
So there is a question about testing in the question and answer section, but I will for now defer just to stay on this topic.
Okay. Then I have one more that I'm going to kind of put in there. Is I was looking into it. I registered through the APPNA for vent management. I'm an ER doc, but when I'm as hospitalist, sometimes you have to take care of vent patients, especially at night. I came across a very good website, and I'll put that in there for those who want to, get extra training and kind of have to know because I see in the questions there's less respiratory therapists. No, we have to co-train, we have to multitask. One person is able to do more things. So I think we should make our nurses, ICU staff, everybody take these courses at least. When one person is not there, they can help manage. It's very important, crucial. So the tier system is we don't have a lot of intensivists, right? And pulmonologists, but regular doctors, I would encourage everyone to take courses for vent management. We don't know where the world is leading to. And then, so even when we get some of our physicians, colleagues, intensivists on tele, then we can speak the same language. We can understand and tell them what's going on. And the other thing is our nurses, our MAs, we can help them do some of these vent courses so they can help out more. That's my advice. And
Dr. Shamsa, you are unmuted. You have a comment, Professor Shamsa.
Yes, I just wanted to. Can you hear me?
Yes, a little bit louder if you can, please.
Okay.
Thank you.
Thank you for this lovely presentation. I just wanted to make a comment about the pulse oximeters and the type of patients we are getting. It is very strange here, the phenomena which I observed, that the patients who were showing all the changes in lungs and they were strongly suspected of COVID, almost all of them, they came negative. Okay, one thing. Secondly, the pulse oximeter is available here, but the type of patients we get, they are really, really very poor. और जब हम बात कर रहे home isolation की, तो he complained on the national TV that I am living in one room house with 20 family members and no one came to pick me from my house. तो सिचुएशन जो हमारे यहाँ पे बहुत डिफरेंट है ग्राउंड रियलिटीज वहाँ के निस्बत, और ये वो लोग हैं जो पल्स ऑक्सीमीटर क्या थर्मामीटर भी अफोर्ड नहीं करते. तो इसलिए मेरा ख्याल ये है कि हमारा सेटअप इज मच डिफरेंट फ्रॉम जो आप लोग वहाँ देख रहे हैं. तीसरी बात, जो टॉप्सीज की बात है, हमारे यहाँ तो किसी भी पेशेंट की टॉप्सी नहीं होती, तो इसलिए वी कैन नॉट से कि ये इनमें थ्रोम्बोसिस था या नहीं था. थैंक यू सो मच.
Dr. Shamsa, can you comment on whether the government will be able to supply patients with economical pulse oximeters? Is there any program?
हमारे स्टेटस के मुताबिक तो बहुत इकोनॉमिकल है. यानी माय फादर ही नीडेड इट लास्ट ईयर, तो मतलब दैट वाज 5000 रुपीस. 5000 रुपीस का मतलब ये है कि तकरीबन $50.
You mean the pulse oximeter? Pulse oximeter?
Can I say something?
जी डॉक्टर निगत, आप कुछ कहना?
जी, आप बिल्कुल सही कह रही हैं. आई थिंक कि अभी वो जो गवर्नमेंट की पंजाब की जो एक निकली है, आई थिंक इट्स अ वेरी गुड डॉक्यूमेंट about quarantine at home and isolation at home. So they are going to make sure that जिसकी घर पे नहीं हो सकती, there's going to be a committee who's going to decide. तो वो तो उनको तो हॉस्पिटल ही आना पड़ेगा या क्वारंटीन सेंटर्स में जाना पड़ेगा. But recently we had seen so many doctors who had tested positive and they were so much worried. They had a place to be isolated at home and all those opportunities, but they were not allowed to. So obviously ये जो home isolation है, ये सिर्फ उन्हीं लोगों के लिए है who qualify for that. हमारे जो majority of patients जो afford नहीं कर सकते, वो तो pulse oximetry को मेरे ख्याल है use करना भी नहीं जानेंगे. So उनके लिए तो hospital ही आना सही रहेगा.
So here's what I would do, doctors. Thank you for the excellent comments. Is you can risk stratify them when you look at them through telehealth, right, or FaceTime them. But yes, if they're short of breath, they're symptomatic, that's it. Yes. Even for little activity, just like New York had classification, you quickly stratify them. If they're short of breath at rest, it's very dangerous. You want to see how can they, when they're going to the bathroom from their bed, even if in their one single room, are they short of breath? That means they're short of breath. I mean, they have to then go in. उस वक्त तो pulse oximetry को कोई काम नहीं है ना. अगर patient इतना short of breath हो गया, तो तलट हो गया, तो अब तो उसको जाना ही है अस्पताल में जल्दी.
और अब जबकि हॉस्पिटल्स भी फुल हो जाएंगे, because we haven't reached our peak at all, or peak तो
I don't think so. I agree.
और उसमें I think our quarantine centers will be full and hospitals are already full. तो उसमें हम लोगों को we need volunteers, and I'm sure अगर volunteers ये कर सकते हैं उन लोगों के लिए जो at least घर पे जो isolate हों, so that you can call in final year medical students, house jobbers, everybody, to help them, monitor them at home, set some guidelines. I think we have made a home isolation program. हमारी team ने बनाया हुआ है.
Excellent.
Okay, we're coming to the end of the lecture. We've gone over. There is a couple of questions from the audience. There is doctor number 601389. You're unmuted if you want to ask the panelists a question. Go ahead, please.
While we're waiting for that person, Dr. Iqbal, there's two very good comment Dr. Rana Suhail made. You know, when we don't have pulse ox, they can count their respiratory rates. That's another very good one. If it's more than 22, 24, that means their work of breathing is more. So, and they're getting short of breath, you can add into this, you know, clinically, where they're in short of breath, but little things are causing them, they can't speak, just like, you know, asthma patients, you also categorize them in the ER very quickly. They can't complete sentences. Those would be another good regular things to monitor, risk stratify them, whether they're going to the hospital now. It's kind of, you need to go in, you know. And the other thing also I would say is try to stay calm, you know, less panic, because, you know, that's one thing we can definitely do. And then
okay, thank you very much for that. I just put the website on the chat box. There is an organization which is an international organization supplying high quality, durable, low cost pulse oximeters to developing countries. It's called lifebox.org or Lifebox. You can look at it, Google, and see if that can somehow help the effort to kind of supply pulse oximeters to people who need them and can't afford them, or institutions that can't afford them. We have, I would say, one last question. That's Huawei 2019. Please go ahead.
Can you hear me, sir?
Yes, very loud and clear. Thank you.
Sir, I want to have a comment and a question from Madam. That how will you titrate the oxygen therapy in the patients of respiratory distress, like low flow to high flow oxygen, because it's very important that when have to we go for the high flow oxygen. And the second, one more thing I also have written on the comment section, that as already mentioned by Madam Shamsa Humayun, I have personally seen a few cases in which the clinical picture was highly suggestive of the COVID, and it was also supported by the radiological evidence like CT, also suggestive, but the lab testing was negative. It wasn't proof. If anybody can guide about it, that how, when should we repeat it, or what is the reason? Are the kits the kits are not functioning well, or there are some discrepancies in the kits? Because most of the patients, I am just sharing you, I think Madam Nighat Mir and Madam Shamsa Humayun will be having the knowledge of it, that two professors of our at Rawalpindi, Islamabad, Dr. Matiullah Mati and Dr. Rizwana Chaudhary, who is the professor of gynae. They both, husband and wife, have the clinical picture suggestive of the COVID, but the lab was negative, and this has created. This is in the social medias. I want to have the comment and the suggestion from the expert.
Okay, thank you very much. Can you just briefly tell me where you're working? Tell us where you're working and in what department?
Sir, I am the regular participant of your the webinars. I am the consultant neurologist at Nishtar Medical University, Dr. Suhaib Hassan. I have already participated in your webinars.
Yes, thank you very much. So Dr. Shamsa and Dr. Nighat, can you comment on the test results?
Was it? I'm sure they must have done one in the after 24 hours, because you know that the sensitivity is only 60%. और फिर टेक्निक भी जो यूज हो रही है, you know, उसके अंदर भी कुछ फॉल्ट्स हो सकते हैं. और फर्स्ट टेस्ट इज नेगेटिव, अगर सेकंड 24 आवर वाला भी नेगेटिव है, एंड आई एम श्योर अगर वो वेंट वगैरह पे थे तो बैल हुआ क्या, उसकी सेंसिटिविटी ज़्यादा है, अप्रॉक्सीमेटली 95%. So testing techniques, and you know, I was attending a webinar. A lot has to be said about that also. लेकिन अगर first भी negative है, 24 hours वाला भी negative है, और 1 week later भी negative है, और अगर patient went पे और BAL भी negative है, I think we might, I don't know whether Bushra is here, but then do we have to rethink about the diagnosis?
So that's an interesting point. I would refer everybody to watch the video from yesterday's session, which was a very comprehensive review of testing state of the art.
Yes.
Dr. Usmani and other panelists. The other question was oxygen therapy titration. If
I can take that unless somebody else wants to. So that's a very good question, and that is the case that I presented, that I was called for ICU consult for BiPAP. I have my reservation, was it COVID positive? Because PaO2, FiO2 less normal, well, if it's less than 300 and definitely less than 200, you want to have a high clinical suspicion. When you say high flow, anything that goes beyond 5 to 6, if the patient requires more than 5 liters, it goes to high flow. It's easier for them to tolerate. So it's kind of more concentrated oxygen given to the patient. And they are those nasal cannulas are kind of thickened and different types, if that was the question.
So one question, and this is from me, because I know that in Northern Italy, which was a very heavy COVID-19 hot zone, they used CPAP helmets, CPAP and BiPAP helmets extensively. Yes. And they were able to prevent 25% of their patients to get intubated. Yes. Is that being used at all in the United States?
Excellent question. And we started reading on all of this. Like I mentioned, I'm finishing off my sleep fellowship here. So the data came out of Italy, and those basically, at that time, the filters were not available, Dr. Iqbal, because we're just finding it out. I think we should be upper hand of it once we hit the peak. I don't think Pakistan or United States have hit the peak. And the concept is, when you wear the helmet, you are preventing the aerosolization, and it's a CPAP. So you are transitioning, helping these patients earlier, limiting. Well, by that time, they already knew they had COVID, because when they had in the upper respiratory posterior pharynx, you don't want infection to go down. But once you have the infection, you want to help out. Yes, excellent. Yes. So see, so there is no way the patient is there is no aerosolization. The patient, the air जो बाहर breathe कर रहा है patient, वो बाहर नहीं आ रही, right? So बाहर जो patient की है, you can see these poor the attendants, they're not using mask. So this patients see there's 2 tubings. The picture that I'm going to send all of you guys on that picture, remember, there's 2 tubings. That's what's recommended. One is the entrance, one is the exit. You see that the 2 tubings next to the patient's left, and patient, instead of the mask, the patient is regularly breathing in the helmet. So he's breathing in and out. You're providing enough oxygen, and the patient that's breathing, that's getting the inhaled breath in is going with the pressure. So it's opening the airway. As you can see, this patient probably has obstructive sleep apnea. This example you gave, excellent. You're giving positive pressure ventilation with oxygenation. This patient probably is not that sick, but it's kind of helping them through. And which is what I was trying to explain, that we can use that here, and we are started already using it actually more in private setting than in university setting, because university setting people are always scared to do something that's out of, but now we have FDA approval for it. So I think helmet would be a good thing, but it's filters are kind of limiting that. I haven't seen, is good question. I haven't seen anyone using helmet actually. So
thank you very much. And I think with that, I want to thank Dr. Fawzia Salahuddin and all the other panelists and all the attendees for another excellent session. Sorry, we did go over the time limit, but there were some very good questions from the audience and useful discussion. We'll table the other questions till the next session or sessions. And I want to emphasize that if anybody is using CPAP or BiPAP in a COVID-19 patients, it should really be done with all attention to personal protection, because this does cause aerosolization and exposure. So airborne precautions are necessary. So thank you very much, everybody, and Assalamu alaikum.
Assalamu alaikum. Thank you, APPNA MERIT, for letting me be here. Thank you.
Thank you very much.
Thank you.
Khud Hafiz.
Hafiz. Assalamu alaikum.